So the goal of this session is to examine the challenges for moving research findings into policy change, particularly with respect to the development and implementation of national strategies on Hep C. So we have three distinguished panel members. Howard New, who took a red eye from Denver so he can attend, is the Associate Deputy Chief Public Health Officer for the Public Health Agency of Canada and directly supports the Chief Public Health Officer in providing public advice on everything, including the kitchen sink, I think. The other panel members are Dr. Dan Worth. He's an epidemiologist and journalist with expertise in HIV, addictions, and drug policy. And he's currently a postdoctoral research fellow at the University of California, San Diego. He is also the research coordinator for the International Center for Science and Drug Policy. The other panelist is Mr. Glenn Betteridge. He's principal at Jonathan Glenn Betteridge Legal and Policy Consulting and a consultant to the Canadian Treatment Action Council. He has experience in law, public policy, and community engagement. So I have a quick slide deck to try and provide some background. So in BC, where we've looked at what we call the BC Hepatitis Testers cohort, looking at well over 1 million British Columbians tested for hepatitis C, you can see that the mortality for people who were tested and negative for hepatitis C up until 2012, from 1992 to 2012, comes in at 6.4%. If you're positive, your risks of dying are about threefold higher. And I can't give you a precise number, but the mortality risks relate to acquisition risks and viral sequelae. And a lot of what we spoke about today is about treatment, which only deals with the viral sequelae. Treatment may be a way of engaging populations, but it doesn't deal with some of the acquisition risks. Clearly, hepatitis C is a preventable and curable disease, and that therefore merits a public health approach. Most of the affected populations are stigmatized. They have a limited political voice. Their acquisition risks are associated with significant harms, costs, and mortality, and even Andrea's vaccine won't solve that. Prevention, harm reduction, a very dirty word in our country for the last decade. Addictions, mental health support is not socialized in mainstream society. Treatment-based cures don't address acquisition-related risks and their comorbidities. So treatment as prevention is just a piece of the puzzle. As we've heard, treatment is expensive. The population affected is large. What is the best societal investment? And we believe that the solutions require a syndemics focus. These populations have multiple epidemics going on at the same time. Treatment cost effectiveness does not equal population impact. It was highlighted by Davis in gastroenterology in 2010, and at that time, they only dreamed of being able to cure 80%, not 90 or 95% of the population. High treatment costs beg for an opportunity cost discussion, and the treatment rhetoric overshadows a proper dialogue on the prevention needs of vulnerable populations. The vulnerable populations are listed above in figurative form. Injection drug use, men who have sex with men, commercial sex trade workers, First Nations, and there's different symbols for First Nations all around the world, people in correctional facilities, immigrants, and refugees. Globally, hepatitis C is a disease of vulnerable populations. And the policy and programs need to reflect the societal and contextual factors that foster disease in those populations. And that current treatment-based rhetoric detracts from creating solutions that address the real needs of some of those vulnerable populations, and yet treatment for hepatitis C can be a window into those populations. So what we hear today is a very large arrow towards treatment with a very small voice for prevention. A lot of what we hear about is equality and costs, but it's really about equity. Equity is about fairness. It's about making sure people get access to the same opportunities, and that's not delivered by just a vaccine or a treatment. Why has the prevention is prevention PASP dialogue been so difficult? As Morris Sherman highlighted, the baby boomers are largely affected. They're a heterogeneous population. Treatment will reduce their morbidity and mortality. And as David highlights, we need to prioritize treating those people. But for people who inject drugs, they need comprehensive harm reduction, needle exchange, opiate substitution, alcohol, etc. And it's important to be part of that package. In the developing world, globally, most of the infections result from unsafe injection practices, and that was only mentioned once today. In those countries, people who inject drugs, they have an even greater overlay of poverty and stigma. Why can't we design and deploy non-reusable syringes, not only for use in this country, but globally? Ultimately, what we need to do is come to a more balanced portfolio, because if the goal is disease elimination and real population level impacts, that's going to require an equity lens. And treatment for hepatitis C is a window into that equity lens. With that, I will ask Harold New to tell us how FAC and the Government of Canada will help us with this problem.
Thank you very much, Mel, for the kind introduction and for setting me up. Looks like I'm going to be on the firing line, I guess. I'd like to thank the organizers as well of this conference for their kind invitation to me to speak to all of you today and be part of the panel. Et pour moi, personnellement, c'est toujours un plaisir d'avoir une occasion pour visiter la belle ville de Montréal. So to start, I certainly recognize it's been a long day for all of us. And so I don't want to make it too much of a didactic presentation, but what I do want to do is give all of you a bit of an overview, sort of the public health, sort of policy development context in which we work. So with that, this is the first slide. And I'll start off by saying that when I first started my career as both a clinician and a public health physician, I had no idea what the acronym FPT stood for. But since I joined the federal government in 1996, it's been burned into my consciousness. And for those of you who don't know what it stands for federal, provincial, territorial, especially in terms of relationships. And it really speaks to the interesting dynamic between the federal government and the provinces and territories based on our constitution. So I've heard lots about different comparisons, different countries, Australia, US, whatever. But I think we always need to keep in mind that we have a unique context in Canada. And based on our constitution, as you see here, healthcare and public health in Canada is a shared responsibility. But the primary responsibility for both the delivery of healthcare services and public health rests with the individual provinces and territories. And it's really up to those jurisdictions to develop, I guess, their priorities, understand their context and realities. And in terms of resource allocation, et cetera, it's really up to them. And that's why you see, for example, why there might be a different approach, for example, let's say HIV testing and treatment in British Columbia compared to other provinces, and why, for example, in some provinces, if you look at immunization, they've decided to, let's say, fund HPV vaccine publicly for all boys, where in other provinces that's still not the case, and maybe it's just females. So that's just an example. I put surveillance as another key function, both within each PT jurisdiction, but also for the federal government, because from a public health epi point of view, it's certainly a foundation in terms of where we need to go, in terms of having the evidence for policy. And then looking at the federal government, it's a long list there. Won't get into all of it, but certainly we also have a responsibility, not to me personally, but I guess other departments in terms of providing healthcare delivery and public health for certain populations under federal care, such as inmates in federal correctional facilities, the RCMP, armed forces, and obviously Indigenous peoples, First Nations people on reserve. Other things like laboratory support, program funding, I think will probably come out in the discussion, so I won't get into that. There is a regulatory function, which is very important, and it's with our colleagues at Health Canada. And the one thing which is not there, which I think is very key, and it's almost hidden, is what I would call a convening, facilitating role in terms of leadership by the federal government, or en français, I guess the role of being a rassembleur. So that, I think, is key, and it happens at all levels, both, I think, at the highest levels politically, but also at an operational level. In terms of this slide, I think a seminal event in terms of public health in Canada, but actually around the world, was the SARS outbreak that occurred in 2003. Many of you, I imagine, were probably involved in some way. I certainly was. And a lot of good things came out of it. Certainly at the global level, it forced the World Health Organization to take a hard look at something called the International Health Regulations of the day, and led to a process to revise and in many ways improve on what they were before. And although it's not perfect, and you see it in the news from time to time, it is much better than it was before in terms of having a framework for all countries around the world to collaborate and cooperate if there is a public health emergency of international concern. And it's come up, and I think every time we have another global situation, it gets better in terms of how we cooperate. So after obviously SARS, H1N1, obviously more recently in terms of even Zika virus and so on, I think we've come a long way. In Canada, personally, obviously had an impact because at the time, myself and a lot of my colleagues worked for Health Canada, but after various, let's say, committees and commissions, and Naylor Committee, et cetera, there was legislation that was passed, and a separate agency, the Public Health Agency of Canada, was formed and reports directly to the Federal Minister of Health. So that's a very key event. But also, and you can see this is what the slide is getting at, there was a whole new structure set up for what we call governance, and how the federal government could or should interact with provinces and territories in a more structured, formal basis. And so something that was created, as you see here, is called the Pan-Canadian Public Health Network. What the heck is that, you might ask? Sounds like bureaucratic gobbledygook. It isn't. It's actually quite important, because this is our direct access to the level right below the ministers of health. There is something called the Conference of Deputy Ministers of Health, which meets on a regular basis. And there's something now underneath that called the Public Health Network Council, which reports directly to the Conference of Deputy Ministers. And you can see here, this Public Health Network Council is composed of my boss, the Chief Public Health Officer, but also the senior officials from each of the PT jurisdictions. So depending on the jurisdiction, it's either a Chief Medical Officer of Health, or it's what I call an Assistant Deputy Minister equivalent. And that's important, I think, for all of you, including myself. It's important to know who the representatives are in each of those provinces and territories, because that, in many ways, is your entry point in terms of putting forward whatever issues are important for the day in your PT context. Underneath that council, there are three main subcommittees or steering committees, as you can see here, one being communicable and infectious diseases, the second one really focusing on what I call chronic non-communicable diseases, and one on public health infrastructure. I think the one of great interest to this group, obviously, is the first one. And just for your information, the committee has two co-chairs, and that's always the structure. There is a federal co-chair and a provincial co-chair. And I think it's sort of very apropos that the PT co-chair, who were in Montreal, is actually from Quebec. It's Dr. Horacio Arruda, whereas the federal co-chair is Dr. Theresa Tam, who's the Assistant Deputy Minister for the Infectious Disease Branch within the Public Health Agency. And myself, I am the federal representative on that committee. The other part that I think is important to note is that there's a close working relationship between what we would call the policy work done by this committee and the Chief Medical Officers of Health, who are more sort of on the front line in terms of managing operational issues such as outbreaks. I won't go into a lot of detail in terms of the Public Health Agency of Canada response. I think many of you are familiar with the various things we do, the types of research we fund, guidance, prevention, and so on. so I won't get into too many details. I think they'll probably come up in terms of the panel discussion. I will say that certainly from a federal perspective, I think we've come a long way. There's obviously some issues that we certainly, I think, need to have ongoing conversations with all of you in the room and others who aren't here today in order to, I think, collectively better address our response to hepatitis C. But with that, I think I'll just go on to the next slide, mindful of time. And this one I think is interesting because even for myself, having had, I guess, 20, 30 plus years now working in various contexts, and I think I've been fortunate working both at municipal level for the City of Toronto Department of Public Health, then at the Province of Ontario, and finally with the federal government, this interface between what we call science and policy. Both sides are important, and I think sometimes there is this sort of maybe misconception that you don't understand each other. Certainly you can't do policy in a vacuum without the scientific evidence. On the other hand, science does not, how you say, rule on its own, and there are many other considerations that need to be taken into account as well when policy is developed. The key point I think I would raise here is that policy that gets developed needs to be specific to the authorities and the mandate of the jurisdiction you're in. So just in the past, I've certainly been fortunate to be involved in some interesting initiatives. At the local level, when you look at tobacco, okay, so what is the role for, let's say, the City of Toronto Department of Public Health vis-a-vis the federal government? Certainly the federal government has the regulatory responsibilities, so things like packaging on cigarette boxes, etc., would be under the federal government. And so in the City of Toronto, in the 90s, we had some tough days, but things such as smoking bylaws, which you can or cannot do in restaurants and so on, that's what you can do based on what you're responsible for. And of course, I think the rest is history, as we all know. At the provincial level, another example I would put forward is hepatitis B. I was involved in the early days when the scientific evidence first came out in terms of the efficacy, effectiveness of hepatitis B vaccine. And ultimately, the province of Ontario, which is responsible, as we know, for healthcare delivery and drugs and so on, implemented a program of universal hepatitis B vaccination for all children in school. No? That's not true?
School age.
School age, yes. So that's two examples in terms of looking at sort of the context in which individuals work. And so in terms of priorities, I'm not going to go through the list. I think all of you are experts in your own areas, but I will make the point that I find it fascinating. I really appreciated the presentations this afternoon talking about research from an Indigenous people's perspective. And I would highlight the final point at the bottom because I too, over the years, having come more from what I would say a quantitative science background, have certainly come to appreciate the qualitative sciences. And I think both sides can learn from each other and need to respect and appreciate what each other brings to the table. And certainly the point about the Western science-based approach versus Indigenous peoples, I think is not unique to Canada. I saw it take place also across the globe when I was in Africa, in Guinea, for the Ebola response, where initially it was all about sort of the Western approach, infection control, what you need to do to stop transmission of the virus, without, in a sense, having the appreciation for what the local culture and beliefs were in terms of things like burial practices. And so quite late in the day, and obviously not too late, there was an appreciation that things such as social anthropologists and having a social mobilization were other things that needed to also be addressed, and having specific scientists and research in those areas were also critical in the response, and not just quote the Western science or quantitative science approach. And if people then say, okay, well, that maybe works over there, but certainly that's not the case here. Another example that's brought up this afternoon, I think, is the example of the anti-vaxxers. And I guess my personal opinion, it's my own personal opinion, is that it seems to me right now there's more of a bit of a war saying, well, if we just show more evidence and whatever, we'll get those people to, finally come to reason. I think we need more research, qualitative, et cetera, to maybe determine what are the motivations, why this certain community of people believe or have this certain paradigm, and then hopefully in a different way approach the issue so that collaboratively we'll get to the positive outcome we all want. So with that, I thank you very much. If there are any questions or comments, certainly the address, email address down below, we'd be happy to respond, and looking forward to the panel discussion.
Thank you very much, Howard. What I'll do is We'll have the other two panelists speak for 5 minutes, and then we'll just open it up for the audience. So the next speaker is Dr. Dan Werp.
Thanks so much for having me. It's not super relevant, but since that bio was written, I have gotten a job. So I'm now assistant professor, UCSD. Doesn't change what I'm going to say, but just figured, thank you. Not even my parents applauded, so this is new. First of all, I'm really glad that we're having this panel today. I am not an HCV expert by any means. I am an epidemiologist, but today I'm going to be sort of wearing my policy analyst hat. And I was struck by what Mel mentioned about this whole paradigm where treatment is really sort of like this monolithic structure that is overtaking some of the more traditional or conventional responses when it comes to prevention. My talk today, very brief, is going to focus entirely on prevention, and it's going to focus mostly on how scientific evidence can be used to address vulnerabilities or address policies related to drugs. So there's I'm just going to give a brief overview of two areas where Canadian researchers, scientists can engage on this issue. And one is internationally, and one is nationally. So we all know that we have a new government in place. We all know that the shiny object when it comes to drugs is cannabis regulation. But it's also really important to understand that we're in a really interesting policy window for a number of issues related to drugs that touch on HCV. First and foremost, I would say, we're at the beginning of a mandate for this government, and this government is putting together its drug policy as it goes. The plane is flying and it's being assembled at the same time, or however that metaphor goes. So because we're so early, there is a real opportunity for researchers to engage right now on issues. And we have a window, it's not a large window and it's getting smaller by the moment, to start setting policies for this government when it comes to issues related to drugs. And obviously, HCV risk among people who use and inject drugs in Canada should be at the top of that list. Related to that, and it's interesting timing, is that not only are we at the beginning of a mandate for a new government, but the National Anti-Drug Strategies mandate is going to end in 2017. So it's not just that we have this fluid policy window, but there is a formal process that's going to begin quite soon wherein this government has to craft a new strategy for drugs, and it has to do so formally. So this, again, is a time for people working in this field to highlight why these issues should be at the top of mind of people who are working on these issues in government. And I would mention two major areas within that I think we could really, as scientists, influence. The first is in supervised injection facility policy. So yes, there was the Supreme Court decision unanimously in support of the medical benefits of supervised injection facilities in terms of preventing transmission risk for diseases like hepatitis C. Very important. The government, as you all likely know, then implemented Bill C-2, which was a bill that effectively circumvented the Supreme Court decision by putting together so many different restrictions on where and how the process could be where and how the process had to be undertaken to actually implement a supervised injection facility, that it made it effectively impossible for municipalities, communities to implement supervised injection facilities, which as we know, are one of the most evaluated prevention programs in Canadian history, and shown to be one of the most effective in terms of preventing hepatitis C risk among people who inject drugs. So, what does this mean? Well, it means that while Health Canada has signaled a new openness to considering exemptions from the Controlled Drugs and Substances Act for the implementation of supervised injection facilities, there is still Bill C-2 on the books. And while Health Canada employees or staff, or I don't know what we call them, civil servants, will tell you that Bill C-2 is not a barrier and is not being treated as a barrier to the implementation of supervised injection facilities. I actually find that really hard to believe. And the fact is that while Health Canada is making a lot of noises around prioritizing harm reduction and prioritizing these evidence-based responses to hepatitis C risk, they are unwilling at this time to move on Bill C-2. So I think we need to demonstrate to government not only that hepatitis C risk is serious among people who inject drugs and is a major public health crisis in Canada, but also that there is legislation in place that needs to be repealed or revised to ensure that we can actually implement the kinds of interventions that Canadians themselves have shown to be effective. I'm not going to go on for too long. The other main domestic issue that I think we can really engage upon is this jewel of this mirage of prison-based needle and syringe programs that so many people have been working towards and trying to at least implement in a pilot fashion for so long. And I think we do have an opportunity right now, as I said, given these multiple windows, the new mandate of the government, the closing mandate of the current national anti-drug strategy, to start to demonstrate to the government why prison-based needle and syringe programs should be implemented in Canada. And these are the kinds of issues that can really only be dealt with by scientists and researchers working in the field. And there is no, Dr. New presented a number of different ways that we can engage formally, but there is no recipe for informal engagement with the government. You just have to find a contact and work as hard as you can to engage wherever you can, along any point of impact with government, be it municipal, be it your local city councillor, be it someone who is a policymaker or works in Health Canada or another related division or department or ministry. This is just something that has to be undertaken, and honestly, I give this government a lot of credit for at the beginning of its mandate definitely showing a lot of openness, but I do think that we need to take advantage of that openness. I will briefly touch on, if I may, the international dimension, because this is a really interesting time internationally. There is a UN General Assembly special session on drugs that is occurring in April. This is the first time that the General Assembly is going to consider the world drug problem in about 20 years. The last time was 1998. At the time, the slogan of the meeting was, "A drug-free world, we can do it." Not only can we do it, but we can do it within 10 years. So we're now almost 20 years down the road, predictable outcomes. The point here, though, is that there's one document that is going to be this, and excuse the acronym, I didn't come up with it, this UNGAS, UN General Assembly Special Session on Drugs. This UNGAS document, this UNGAS process is going to produce one outcome document. And this outcome document, while it's very high level and very UN and opaque, is going to list a number of ways in which the international community is going to sort of set strategy for the international community to respond to drugs. And so far, we've seen 3 iterations of this document. The first came in January. And none of them have been able to use the words harm reduction. And this is a major failing. This is obviously a major failing. I don't need to explain to you why. What is very problematic is that this government, while publicly committing itself to harm reduction in a number of different ways, our government has not engaged at all on this issue. Now, why is this important? Because the language of this UNGAS document, the UN is like an echo chamber. You stick something in and it bounces around and starts hitting everything else. So this UNGAS outcome document is going to influence the language in the UN, the outcome document of the UN high-level meeting on HIV/AIDS, which is happening in June. So the restrictions that are placed on UN member states and agencies in this current UNGAS on drugs are going to then focus and restrict what governments can reasonably do with HIV, which has a knock-on effect on hepatitis C, and so on it goes. So the one very brief thing I would say there is that we need to push Canada to really advocate around its domestic priorities on harm reduction, and do so not only domestically but also internationally, and we can get into how we can help them do that. Thank you.
Thank you, Dan. I'll ask Glenn Betteridge to come up.
Great. Thank you, Mel, and thank you to the organizers, especially Dr. Klein, for extending an invitation to me to be here today. My goal is to turn you all into advocates in 10 minutes or less. So a cure for hepatitis C exists. We have drugs. Drugs have patents. They're expensive right now. We have a group of committed and world-leading researchers, both in clinical and public and basic science here in Canada. And we have public and private drug plans and the bodies that provide recommendations to those plans, looking and re-looking at medications, the DAAs, and the circumstances under which they should be used and paid for by those private plans. So what do we do now? I think the focus today has been, and the talk has been about getting drugs into bodies, reducing morbidity, saving lives, reducing incidence, and working on improving the social determinants of health, which are both a driver of hepatitis C transmission and structure, in large measure, what outcomes people may have on treatment, or whether they actually get into treatment in the first place. So my organization works to improve timely, affordable, and equitable access to HIV and hepatitis C medications, and I think that's a goal we can all share with respect to hepatitis C medications. Recently, I've been going to a number of conferences around hepatitis C, and I see slides like this. I see the old days of HIV portrayed. I'm on the ground there in one of those slides. So this is a time near and dear to my heart, but guess what? Times have changed, and times have been changed by the people who advocated in the HIV movement for changes to regulatory structures and drug access. The need for collective action, however, has not changed. So in thinking about how we do our activism and what types of activism, we need to take into account the differences in time and, importantly, the differences in people affected by hepatitis C versus the early years of HIV. Fair to say, these are marginalized populations, or more accurately, they're populations or groups of people that society has marginalized. It's a dynamic process of social, economic, and as Mel mentioned, political exclusion. So what we need, and what I've heard in this room today, is a commitment to addressing the health inequity. Activism requires social capital. I've been struck by people with a great deal of social capital putting slides up and imploring people with very little social capital to get up and advocate. I think this is where the call for a rapprochement between basic health sciences and quantitative science and qualitative science comes in. Let's understand the fora in which we're being called to advocate and who has the power to do advocacy in certain places. So social capital is related to health, and in particular, the one I want to focus on, or the two that make sense to me, are access to information. So we've heard today that Indigenous communities and Indigenous people don't have access to basic information about hepatitis C and ways to protect themselves. But I also want to talk about the political mechanisms, or the political economic mechanisms, and who has the social capital to push those. So I want to talk about our aim of addressing health inequity and moving that to action. I think it's people like you and me, well-educated with incomes, who have connections, who have jobs with a fair bit of flexibility often, to take up the call. The title of the session was about knowledge into action. And so I'm going to suggest that the CIHR approach is deficient at this point in time. So I'm just going to flip through a couple slides and talk about accelerating and action. And to change policy and practice, the translation of research is necessary, but not sufficient. Absolutely necessary, but not sufficient. The KTE model we have now is built on a very rational view of decision makers and what influences policy change. I think Dan's recounting of insight and harm reduction and its path in Canada, despite the overwhelming evidence, attests to that. It's blindingly obvious. There's a body of literature critiquing knowledge translation in exchange for its simplicity. And I offer you on the right a schematic from a paper by Dr. John Lavis, who's a world-renowned researcher in the field of knowledge translation. This schematic looks at the use of one tool, evidence briefs, to change clinical policy. That's the schematic. I don't want to go back and remind you of what the CIHR schematic was. It's a lot more complicated than CIHR would have us believe. Here's where I start to turn you into advocates. For those of you who are clinicians of one sort or another, I can find you somewhere in your code of ethics or the legislation which allows you to be a self-regulating profession, an obligation, a responsibility, a duty. We're in Quebec, so this is the duty of Quebec physicians. You must protect and promote. That's human rights language. Respect, protect, promote. You must protect and promote the health and well-being of people in your care, both individually and collectively. You must collaborate with other physicians, maintaining and improving availability and quality of medical services, continuum of care ending in access to hepatitis C treatment, and prevention of reinfection. So let's get practical. I'm going to offer for your consideration 12 ways that you might become an advocate. Some of you are already advocates, but there may be some in here you haven't thought of. So, building community representation into clinical and public health research, from agenda setting through KTE. I was pleased to sit down for over 2 hours yesterday with the national director of the Canadian cohort, co-infection cohort, and talk about ways to further engage community experts with lived experience. Present your research evidence to people living with hepatitis C and staff at frontline and community-based organizations. Ask them what they think and what they need from you. Convene or participate in multidisciplinary think tanks or meetings that include people living with hepatitis C and their representative organizations. Write or sign petitions, letters, open letters. What is the new Trudeau government going to do for UNGAS? Prepare summaries of your research specifically directed at a target audience that has control over the levers that you want to move. Community is one thing, and to develop community-friendly and plain language summaries, it's a totally different audience from ADMs. And meet with those people. They're friendly, welcoming even. They're your peers, your colleagues. Perhaps you went to school with them. Time to renew old acquaintances. And nowadays, especially the drug plans. My colleagues and I have been to meet with the director of the Expanded Sectional Access Program in Ontario, which controls access to all hepatitis C DAAs. Lovely, welcome. It was a great session. We learned a lot, and we provided them with a lot of feedback and some interesting ideas. We were invited back. So correspond or meet with elected officials or their political staff. There's two sides in politics, civil servants and the paid political staff that travel with people who are often the ones who are going to set policy and policy directions. Engage the public. Talk to journalists. You have specialists within your organizations who can prepare you to do that and prepare materials for you to do that. Join a professional organization like the nurses. Nurses are the great social justice fighters in harm reduction, HIV, and hepatitis C. Sit on boards or committees of community-based organizations. Let some of your social capital rub off on the organizations. Constantly strive to bring hepatitis healthcare to people who need it where they're at, as opposed to vice versa. And importantly, leverage the relationships and influence you have with innovator pharmaceuticals, or what we used to call brand name pharmaceutical companies. Your interests align very closely in terms of getting meds into bodies, if that's the end goal. And there's lots of partners, and that's my organization, and that's me. Thank you for your time.
Thank you very much. Now it's your chance to reflect on today's discussions and ask questions of the panelists. Jason.
No one's going to do it. All right. So this might be for, I apologize if I pronounce your name wrong, but Dr. New. And it's not meant to be sort of an adversarial thing, but really to sort of start to have some constructive discussion. Look, I understand, given everything, the difficulties in terms of all the provinces having a mandate over their own sort of domains. What are, in your opinion, well, first of all, I guess the question is there plans for a national strategy or national action plan for prevention and treatment of hepatitis C in Canada that's kind of on the cards? I know there was one by PHAC, but didn't really have the action component in it. And if not, what do you, and maybe even from the previous speaker, which was fantastic, by the way, what, if not, what do we need to do, and what do you want from the research and medical community and the community, the affected community? What needs to happen in order for us to get this going?
Is this hello? Okay, this works. Good question. I guess my first response to that is that throughout my career, I've heard the word strategy in so many different ways. And in my view, strategy means different things to different people. My minister, and the things I'm going to mention as well, is that one point that's important to say is that even though I'm a clinician, a scientist at heart, I'm also a civil servant. And in that space, you recognize that as part of my job, but also all my colleagues who work in the federal government and other levels of government as well, our job is to provide what we call fearless advice and then loyal implementation once a policy decision is reached. Certainly, I think there's been a lot of good comments about the new government, the fact that we have a liberal government, and certainly I already see hints of sort of policy shifts or changes compared to what's happened before. What I've seen, I'm just like you, I sometimes pick it up from the news, see what happens in media scrums and so on. And I've seen our new minister, Jane Philpott, indicate that she is keen on more concrete actions that, quote, her officials, myself included, can have with their provincial territorial counterparts that actually really address hepatitis C, as opposed to this somewhat nebulous, to be honest, this strategy, national strategy and so on, which could take years, and we could be spending months and years just debating, arguing what it means in terms of different contexts and different audiences. So my take is that let's focus on what we can do concretely, taking the cue from our minister. And in that, as I mentioned, there's various structures, and I'd be happy to discuss maybe the best way that you as a group of researchers could either influence provincial policies, as well as maybe who your reps are on the various sort of FPT committees and figure out the best way to move things forward.
Sure. I guess just to add, because you said, strategy means different things to different people. And look, as a Canadian, having gone to Australia, I've found it pretty impressive being in Australia over the past 9 years. They've had a national strategy in place now, I think, for several iterations. And I guess the key components of the strategy are actually having some goals around prevention, management, and treatment, and then actually setting some targets for what they want to achieve over the next sort of 5 years. And then some actual things in terms of actions that's going to be done over the next sort of 5 years to actually get to those targets. And I guess and Scotland has done, and I think if we could bring in some of the places that have done this, Australia's done this, Scotland has done this, France, the US, and bring some of those people and even share those experiences to Canada to see how we might be able to go about doing this, because we're in this sort of deadlock. We always go back to the fact that the provinces have control, but and I'm not trying to attack, but I just think we need to have a discussion about it.
Let him answer.
I agree with it. The thing is, it is the unique Canadian dynamic, and I don't want to get into comparisons with other countries you mentioned, like Scotland, UK, and so on. Let's say in England, they have the national sort of a health system where it is a single unified system.
Yeah, of course.
And the fact is in Canada, and that's the reality, the provinces jealously guard, if I could say that term, their responsibility for delivering healthcare services. And we sit in one province, Quebec, which sometimes has a completely different approach compared to other provinces in a number of different areas. And
Sure. Yeah. So again,
that
I just
is
like
what
to.
is that's
Okay,
the
Jason,
reality.
there's other people in the
I know. I just want to thank you so much for coming today. I don't mean to be, and I think this does start a new potential opportunity to kind of move forward on this. So.
Yeah, and I'm excited too, and I can just say, personally, as a public health physician, I mentioned, people have talked about things such as harm reduction and so on, and the fact is that there are new signs coming from our political masters, so to speak, that they are using the term, and our minister is open to having further discussions and recognizing that it is part of a comprehensive approach. I think that's all positive, and I think it's something we should all embrace and move forward with that.
Jordan.
So I guess I'm going to reiterate some of what Jason said, and I think it follows on really the point that the second speaker made about the UNGAS, and that you get, once terminology, it is very powerful. And actually, I think that the WHO has finally put hepatitis on the radar screen, has raised I guess just the relevance of hepatitis globally. And even if you're right that provinces still have ultimate jurisdiction, I guess I would argue that when the federal government comes out and says, this is what you should do, you can decide how you will implement something, but this is the basis for how you should think about healthcare and addressing this issue, and then each province may choose to decide to implement that differently. That still provides, basically, in a way, it forces the provincial governments to at least think about it. And I guess I would actually use the example that you raised about hepatitis B vaccination in Ontario, which frankly we're one of very few places in the Western world that still has a very outdated hepatitis B vaccination policy. And that's partially because I believe, because we don't have national leadership on saying that we have an outdated public health policy and we have provinces doing different things. But if the federal government said we should be using the best science to inform the decision about vaccination policy, I think Ontario would change their policy, because they would recognize that what they're doing is out of sync with the evidence and the science that's driving it elsewhere.
When?
Yeah. A few things come to my mind. PHAC is not CDC or NIH. Never will be, never was intended to be. Be careful what you ask for. We asked for an HIV testing strategy 8 years later, and literally years of community resources in people time and thought went into that. Because you're probably not going to like what you get, so it's going to be a retrograde action fighting to make it better.
I think
Money. Canada Health Act. The federal government has no interest in enforcing the basic principles of our healthcare system over the past decade, and has less and less interest. And under the previous government, moved to block funding, no negotiation, capped. So I think it's a bit, you may be asking for the wrong thing in the wrong political climate. Do we need a national strategy on hepatitis C testing? Why don't the docs and the researchers get together with community and figure out what that would look like in the same way that you guys have gotten together and given us treatment guidelines, right?
Okay.
Why not?
So-
you
so-
have the social capital.
There is a Canadian Preventative Task Force that will be releasing a document in the coming few months. But I think one point you made, Glenn, that's very important. Just as you highlighted that times are different and that the population, vulnerable populations are different, we have to come to grips with the way that we're 13 provinces and territories without a federal government that can actually implement across all of those jurisdictions. So I think that taking that into consideration will be very important.
Just a final comment in response to your question. I would love, that the federal government, myself and others who work in the public health agency actually have the influence and power to do what you're suggesting, but that, what I call prescriptive approach, would never work. It's just the dynamic. I've lived through it. I've worked through it all three levels. Just taking the comment here about, we're different from the CDC. This is my own personal opinion, so this is not a government sort of a position.
We're taping it. It's okay.
Okay, so the CDC, and I've worked extensively with colleagues in the CDC, I would love, I and the public health agency to have the resources, et cetera, that the CDC has. And the way they're able to influence, let's say, public health in the US is that with their resources, they can embed people and money, et cetera, in state departments and influence sort of how public health is undertaken in various state departments. I can tell you that if you tried that in Canada, let's say if we, the federal government, and I'm just speaking for myself, I know I'm on sort of the record, if we offered that to the province territories, yeah, we'll embed people and have this and that, I know what the reaction would be. No, just give us the money and so on, and we'll take care of it, and we'll do what we need to do. So that it's a difference in attitude and culture, and that's something that we just need to recognize.
Mark.
Well, I'm quite enjoying seeing Howard sweat up there. I was gonna change the focus a little bit. So, but I just wanted to continue the conversation about the policy idea and how far back we can peel off the layers of the determinants of health. So I think it's very excellent that the session's ended today with policy, because the focus really is around the determinants of health and how we can, and the prevention thing that Mel was talking about. And I think it's very interesting in BC, the last year, we've had more overdoses than ever before. And this is basically, we've saved 400 treatments of hepatitis C in some ways, because these people will now not qualify for treatment. So even though in a view where we've focused more and more of our activities and our nursing activities and our training and all the emphasis on getting people, advocating for people to get on treatment, harm reduction's really fallen off the radar almost altogether, and things are worse now in BC than they've ever been. And what Dan was talking about and how we get policies and the prohibition and these kind of things that are driving this whole mess at the front of the line, I think, is truly important. And one of the things that we face when we're advocating for determinants of health, we can't afford it, or we can't, but now we're talking about billions of dollars in treatment, and a small fraction of that would totally equip all the harm reduction we'd ever need. It would provide housing for all the people that we're most concerned about. So now the idea that we can't afford it even is sounding quite ridiculous when we're thinking about spending all this money. So I'm sorry, I'm not really asking a good question, but the idea that we could tie some of the discussion we had about how much this is going to cost with what proportion of that money should go to the determinants of health and how we're going to prevent new infections from occurring.
Okay. I think we're close to time, so we'll just allow these 3 questions. Janet.
My first question is to Mel. When you were talking about the global risks, and you mentioned needles, unsafe needles, and what we understood was that it's more related to hospital or institutional acquired infections rather than unsafe needles. So I was just wondering, that's my first question, you can answer it later. And for Howard, You mentioned later about the role, the convening power of the federal government and the ability to bring coherence and harmonization, but it really is an important role in that list that you had. And I think you can now, given the new government, shift it back. And I think it's important for people to see that role as an important role. I have worked in the federal government for many years, the provincial government, et cetera, so, as well as elsewhere. So I think that that's something that we should start telling people about, especially people who for 10 years or may have never experienced the power of that. And related to that is the federal, provincial, territorial mechanisms. It's been 10 years since that's worked well. And there's an opportunity now, and I've seen it work well in terms of harmonization. And you're not being prescriptive, but things can happen if it works well in an environment that's more positive.
Janet, I'm cognizant of the time.
And one more comment is the standing committees, that I think we've lost the ability to think about the role of the Standing Committee on Health and the role we can play in order to get all parties to address this issue so it doesn't become aligned with a certain party, and that we can get these issues of drug pricing and standards or whatever we need through the Standing Committees on Health, and nobody's mentioned that.
Okay. Thank you. Just a quick comment. In many parts of the world, syringes are routinely reused. Multi-dose vials are routinely used. And there's no reason that we couldn't adopt technologies that would prevent that. Frank.
A thought on the idea of social capital. I think that there's also, you have to be careful what you're wishing for, as has already been suggested. A number of municipalities across the country, of course, now don't fluoridate their water because there is public pressure, there's social capital put on, right? So, when we're talking about this, it can also swing the other way. You mentioned the anti-vaxxers, and of course they're cuckoo, but the point that they're making is this idea that there's this big conspiracy in terms of controlling drug prices. Well, they're not wrong in that.
Hi, my name's Zoe. I've been working in the Toronto Community Hep C program for 10 years. We treat active drug users in the urban center of Toronto. I guess my comment is more around Glenn's comment around social capital and the need for specialists and people with more privilege within our society to get involved in the advocacy level. And I guess this is more of like an invitation, because I understand that some of the knowledge that we hold as community organizations, which is really nice to see more representation of here in this room, because in past symposiums hasn't been as large, is an invitation to come and meet with us who are working in needle exchanges in these programs that are embedded with active drug users, not in a research setting, but actually to come and learn. And also, maybe you're not schooled in advocacy, but you could come and learn from us as well, and we could talk to you about the different tools of advocacy we use. And we don't need to be shy of each other in that regard, because I think sometimes we have, over the years, butted heads. When guidelines said we wouldn't treat people who use drugs, that was really hard for us who identify as drug users or working in drug using communities. So just to put it out there that, my name is Zoe, you can come talk to me if you live in Toronto, and we'd be happy to engage with you and invite you, because we do need you, actually. We need you, we need your power. We need you to stop saying that we need a movement from people who are incredibly disenfranchised. I actually think a lot of specialists have a hell of a lot of power, which we could teach you some things to say it the right way, too. So
Thank you
thanks.
very much. Wait. Dan?
So, in the spirit of research to policy, I think there's a very easy way that we could take today's panel and actually do something substantive, which is just to remember that there are so few barriers to engaging on these policy issues. Policymakers, civil servants, they don't want to read a 10-page report. They don't want to read a 5-page report. They want to read maybe a 2-page summary. So if I would urge you to collectively organize and lay out very clearly and succinctly and briefly 10 recommendations around HCV that Health Canada and others in government need to address. Sign it, get as many people as you can to sign it, even if it's 10 august researchers, and just send it to government. Find a contact and send it and request a meeting. And I think you will be surprised at what you can accomplish. And it's very easy, the barriers are low. I would just like to leave you with that.
Thank you very much, Dan. That's actually very fitting because there's a scientific American thing about the power of 10. So I think that that needs to be what we need to do. So with that, I'm going to turn this over to Marina, who's going to close the day. Thank you very much.